Dr. Vinay, can you see the message also?
Yes, sir.
Now, Dr. T.D. Yadav, sir, has come. Now, you please start. Sir will moderate the case for us.
Am I audible, sir?
Yes,
Yes,
you are.
go ahead.
Morning, sir. Uh, uh, my patient is 65-year-old female. She's from resident of 2 years, for which she was evaluated and she was diagnosed to have uh, gallstone in the month of May 2025. Then she underwent laparoscopic cholecystectomy at the outside hospital on 5th of May, and the duration of operation was around 60 minutes, and operative period was uneventful. There was no drain placed, and there was no history of any intraoperative blood transfusion of blood products. And a patient attendants were showed the specimen of the specimen, and histopath report is available, that is chronic cholestasis. However, there is no notes are available regarding the surgery. The patient was discharged the next day, and then on first of day 2, the patient developed second after surgery. She developed pain in the right upper abdomen, which was dull aching, non-radiating, and it was not relieved with oral analgesia. On next day, patient also developed high-grade fever associated with chills and rigors. And with these complaints of upper abdomen pain and fever, she was admitted at the same hospital, where she was informed to have infection in the bile. And after that, one drain was placed uh, in the right upper abdomen. That is on 6th day after surgery, which initially drained 300 ml of thick green yellowish fluid. Following the insertion of the drain, the fever gradually subsided over next 3 days, and she was discharged home again with the drain placed, and with the output of the drain was about 800 to 1000 ml per day, and the output gradually reduced over the next 1 week. And following that, after 1 week, again she developed fever with chills. Then again she underwent another procedure, that is another placement of drain under the ultrasound guidance at the same center on 22nd of May. That is 16 day, 17 day after surgery. Currently, the drain is draining about 700 to 800 ml of thin, bright yellowish fluid per day, including both the drains. And patient is passing clay-colored stool. There is no history of villous discoloration of eyes and urine. There is no pleuritis. There is no hematemesis or melena. There is no history of loss of appetite or loss of weight. The patient has history of loss of appetite and loss of weight, which is since the surgery. However, there is no history of any easy bruisability, dryness of eyes, or wound pain. Coming to past history, she is a known hypertensive since 5 years on medications, regular medications. The personal history, she consumes mixed diet, and she has normal bladder habits. However, passing clay-colored stool, and there is no sleep is normal, and there is no addictions. To summarize my history, sir, she is a 64-year-old female who underwent laparoscopic cholecystectomy 3 months back. 3 days later, she developed fever along with upper abdomen pain, which subsided after placement of drain, which initially drained about 500 ml of greenish yellow fluid, and which reduced output and associated with recurrent fever. And then she was symptomatically better after placement of additional drain, which the drain color has changed from the green to thin bright yellow gradually, and currently daily output is around 700 to 800 ml. And patient is having E. coli stool. So with this, what I think at this level is probably external biliary fistula, sir, following a laparoscopic cholecystectomy.
Okay. So you have said that duration of surgery was 60 minutes.
Yes, sir.
Hello. So
Yes,
why do
sir.
you have how does it correlate clinically to make your further progress?
The duration of surgery, sir.
Yes.
Sir, if there is any intraoperative difficulty, the duration of surgery will be prolonged, sir. So,
Patient did not have difficulty, but still you are saying there was a bile. So what does it mean?
that indicates surgery probably had uneventful, or the surgeon did not notice any injury intraoperatively, but however, postoperatively patient had bile leak. So it usually happens with any cystic stump load or minor leaks.
So I'm not asking the diagnosis. So what are the at this stage when somebody tells that patient surgery was uneventful, only 1 hour has been taken and no drain, nothing, but bile is coming. So what is the first thing you will do when patient comes to you? What are the things you would try to look into?
First, I looked into the uh, hydration status of the patient, sir, whether the patient is using sepsis.
Management. To make your vision about the further this problem, patient has, you are saying patient had a very straightforward gallbladder surgery. What are the things you would like to look into? Okay, let me ask you, does ultrasound help if you see the preoperative ultrasound?
Yes, sir. Preoperative ultrasound, sir, if there was any presence of IHBR or presence of any
That nobody will go and
stone.
do you think anybody will go and do surgery when IHBR is there? So in a nutshell, what are the risk factors for the bile duct injury?
Any history of cholecystitis, sir,
If
preoperative.
you were told there was none, and
Uh,
that is the only one thing, history of acute cholecystitis, no other high risk factors for the gallbladder surgery, bile duct injury, or even conversion.
sir, whether there is any if there is a presence of any uh, uh, CBD stones, sir, or
What will be shown on ultrasound? If there is ultrasound in the CBD stone, who is going to operate? Again, you are coming back to the same thing. First, you said ISBRP, then you are saying presence of stone. Is somebody going to operate with the presence of stone? What are the other factors? Stone is not going to. Stone is something which is within the. If ultrasound shows stone, then who is going to operate? So let me ask you then, if there is a mucocele of the gallbladder, what happens? Is it a high risk for bile duct injury?
yes, a mucosal. Yes, sir. That indicates there may be impacted stone in the GV neck or
No, that is
prothecalus.
that is stone. But how does it prevent bile duct injury? So if there is an impacted stone, what happens to the cystic duct?
Instead, it will be shortened or it will be absent, sir.
Then what will happen to the bile duct?
Uh, so bile duct will get, the calyx will get obliterated, sir. So,
Bile duct will be normal, not the calyx. I'm asking bile duct. You people don't listen the question, go on answering. That is the biggest issue. When there is an impacted stone, only single impacted stone, most of the time, there will be very small cystic duct, and the same would be for the bile duct. And when you pull it, you have a tendency to dissect in the common bile duct. That is one of the very common reason if there is a mucosal of the gallbladder. You should know what are the high risk factors. What are the other factors which might be responsible?
there is associated chronic liver disease, sir. Whether any cirrhotic changes in the ultrasound preoperatively.
You are going here and there, but not in the ultrasound. So you don't read what are the high risk factors. Is obesity a high risk factor for the bile duct injury? It is. If you have not read, let me tell you. Small contracted thick wall gallbladder on ultrasound. Is it a high risk?
Yes, sir.
So bile duct, dilated bile duct might be missed, and where there is a predictor of stone, not the presence of stone, not the IHBRD. Dilated bile duct alone is a predictor of the stone, and that might be missed. That can produce in the when bile flow is too much from the bile duct, it can produce the cystic duct bloat, as you said, but not that there is a presence of stone which is obvious on the ultrasound. The presence which is unsuspected stone, but in a good vision person can suspect the stone. Liver function test. Would you like to see the liver function test before surgery?
Yes, sir. Preoperative liver function, sir. Whether there any
Because of the blockage without IHBRD in ultrasound. Sorry, in a LFT.
elevated alkaline phosphatase, sir.
That is very, very sensitive but very non-specific marker. How will you make it better? It's a predictive specificity. How it will increase?
Along with ALP, we will also look for GGT, sir. So that will indicate.
And there is nothing in the OTP.
OTPT will also be elevated, sir. If there is a
the transient elevation of the ATP. So all these things are very, very important when you are having this, and you should go and look it into. Not that what you are going to learn from this surgery. That is the main aim of presentation. So you said in the beginning, you said that day two there was a pain. So once
Yes,
done a polycystectomy, how will you suspect that there is a bile injury or bile duct injury if there is no drain?
if the patient have fever along with the pain, sir, it will be the decom.
Yeah, but bile is usually sterile. There are bile, but usually it's not this thing. Bile will be there, but not that it is bacteria. So on day one, you are thinking that there will be fever.
If the sir on day one, if the patient is complaining of persistent pain and which is unusual, not usual, then not the like usual recovery. That along with if there is a right problem of tenderness, then we'll get then we should suspect bile leaks.
What are the unusual recovery in the post-operative period that alerts you as a registrar?
Patient is having tachycardia. Patient is having persistent pain, not only with analgesics.
So you experience that unusual pain. Pain is not that what happens that at a port side there is a little bit of pain. Patient should be comfortable, up and about, little bit of pain, taking orally normally, not this thing. Then you see the clinical signs. You people only start tachycardia, means you are thinking only of sepsis. So before sepsis, you cannot diagnose a collection in the abdomen. So these are the factors by which you can think that there's something is happening. If you start the search to settle, then it is late. So what is our aim? Our aim is to diagnose at the earliest to have a better outcome. So if there is an unexpected recovery, that includes unusual pain, unusually severe pain, site of the pain. Then you go and examine. There is a tenderness in the abdomen, maybe. It may not be present. Then there may be tachycardia. Face is not that looking comfortable. Some uneasiness on the face. So these are the factors which will suggest that this patient had some sort of something going on. Then what would you do?
Then we'll do ultrasound, sir. Ultrasound abdomen website to look for any collection is there. And
And liver and complete blood count. Why we have to tell all these things which are the basic bedside treatment? You will only do ultrasound. You will not do liver function. You will
I
not.
will do
Everything has to be done when patient is having unusual recovery, and then only you can diagnose at the appropriate timing so that you can avoid complications, further complication of the bile draining into the peritoneal cavity. Peritoneal cavity is a culture medium. So if it starts going something which was not producing symptoms, sepsis will start settling. Usually doesn't happen on day one. Very rarely it will. Or so this is the patient where you said that day 2 was it a daycare surgery?
She was discharged the next day early morning. Next day morning she was discharged, sir. So
The morning surgeon comes and discharges. Okay. Now you have said that in the beginning she started with the pain and then fever with chills.
yes, sir. Day 2 she had a pain, sir, and day 3 she started having fever and associated with chills.
Fever, you have said fever with chills.
Yes, sir. Fever with chills.
Does it alerts your mind when there is a fever as such or fever with chills?
So fever with chills indicates, sir, that it is infected and it is that some it was abscess formation.
Sepsis will not occur on day 2, Dr. Vinay. Usually it is, so there may be suspicion of cholangitis. Cholangitis will start with fever and chills. If the abdominal collection might have fever, might have tachycardia. Chills usually is a little bit later sign. That is, so this patient again then this is happened and subsequently 500 you are seeing output, then 800. Now you are saying this is a controlled biliary fistula.
Yes, sir.
For 3 months, it's having a controlled.
Controlled biliary. Initially uncontrolled, sir. Later it become controlled biliary.
What are the in a patient when comes with a 700, 800 bile output daily, and you are seeing this patient, how you are going to proceed? I'm not talking about investigation. What are the things you look into this patient? What are the nutritional derangement
Yes,
because of this?
Bring loss of bile. So patient can have signs of fat, like fat soluble vitamin deficiency, sir. Earliest to manifest will be the that vitamin K deficiency. The patient can have easy bruisability, ecchymosis.
Vitamin deficiency.
Sir,
Easy bruisability is a sign of coagulation factor defect.
presence of ecchymosis and
Both are not the same. If you scratch your skin and there is a bruisability, what does it indicate?
thrombocytopenia.
Then, so don't go on at your stage. You should be very careful when you are answering the question. So first is vitamin K. What are the other vitamins?
Vitamin D, sir, that is present. Patient can have bony pain or muscle weakness, and vitamin A rarely can present. That is present with patient that can have decreased night vision and dryness of eyes.
Other nutritional things will not derail. Only vitamins will be affected.
Now, the patient can also, this patient uh, can patient will also have nutrition patient loss of weight, sir, and because of nutritional deficiency.
What nutrition? What are the specific nutritional deficiency will occur? Patient is taking normal diet when bile is coming out. Fat is not getting absorbed, any type of fat. Don't you think anything is going to happen in the regular metabolism other than only vitamin deficiency? So many things happen. So let's. I think you people should read little bit more about the external fistula being managed for such a long time. Every day, 7 electrolytes would be deficient.
Electrolytes will be impaired, sir. Usually, patient can present with hyponatremia and associated metabolic acidosis.
Why should be metabolic acidosis?
Uh, um, so because of loss of sodium, sir.
Lots of sodium will cause hyponatremia, not the acidosis. Lots of alkali. What is the pH of the bile? It is
Uh,
a solution. So many alkali being wasted daily, throw. And don't you think that there can be a chance of metabolic acidosis? There can be chance of severe deficiency of all the fatty content, and that's why the patient will have other metabolic dysfunction. That's why they will become they lose their weight if not properly managed. Okay, so this is the external brief fistula, and in this due course of time, on day 2, day 3, once you have put a drain and all, when you are
yes,
going
sir.
to start the patient.
Sorry, sir. When
At this stage, when you have been able to achieve a controlled biliary fistula,
yes,
then
sir.
starting the patient, what would you do?
Sir, that is in the early post-operative period, sir.
Yes.
Sir, well, yes, sir, we'll confirm that patient is having no collection. Then there is by ultrasound CT. Then uh, then I will plan for early uh, endoscopic management, sir, if the drain or
Okay. So will you do something? Will you send the patient for the ERCP straight away?
no, sir, we'll get MRCP, sir, prior to after draining of collection. Once the sure of the patient.
What is the appropriate time you are getting an MRCP? So MRCP would be of no use if you are having a bile in the tummy, meaning thereby if there is not a very good controlled fistula, it will not show anything. So you have to first control fistula nicely. And
Yes,
when why you want so much early endoscopy? What percent of the bile duct injury today in the laparoscopic era? What is classical bile duct injury?
classic.
Classical laparoscopic bile duct injury.
So classical bile duct injury, there will be a complete transaction of the CBD. There will be segmental loss of CBD and the CHD cell. So
That's
there
all.
will be complete discontinuity will be there.
Have you read this classical laparoscopic bile duct injury? It goes by somebody's name. It goes by name of the some person who described it for the first time. You don't know. So all of you at least should read the article by the 1995 article by Strasberg. bilateral injury. People don't go and read the articles with so much of bilateral injury is coming or happening in our country, published in Journal of American College of Surgeons. So David Dodds is first described, and it is associated with the right hepatic artery injury. So ERCP also produces some sort of complication. What percent of the people will develop acute pancreatitis based on after ERCP in a best hand?
About 10 to 15%.
10 to 10 is too much. Close to 5% may develop. What percent of people might have a duodenal perforation? Same up to close to 5%. What percent of people might have a bleed after EPT? So you see when you are prescribing, there is already damage done. So until unless you are sure that my patient is going to be benefited from this investigation, then only you will do it. You will not try to flog the tired horse. So at least what we follow, we do a nuclear scan. And HIDA scan, HIDA is a very nice uptake is there, though anatomically it is poor. But at least even minimum amount of this bilirubin going into the tummy, it takes. But many people don't like it. But yes, MRC should be done at the most appropriate timing before discharging. That you should have an idea and tell the patient this thing has happened, other than doing endoscopy. So if there is a continuity, you can do endoscopy. If there is no continuity, it might not be helpful at all, because the endoscopy is not going to help. There are some people they try to go beyond this thing, but at your level we should not be discussing that too much. So we should establish the continuity. Then only we should try for ERCP. So go ahead for the examination now. So it's a very important. I give some time. Very important for all of you to know each and every aspect of the bile injury, because it's a benign disease which has happened. So now, as you have said, chronic cholecystitis already diagnosis has come, but thickness of the gallbladder, all those things should be looked into. Sometimes not a very good pathologist will tell you the chronic cholecystitis. We have reviewed the slide and found that there was adenocarcinoma. So you should be very, very careful. Go for the examination.
General physical examination, patient is averagely built and nourished. She is alert, conscious, cooperative, oriented, time, place, and person. With a BMI of 20 kg per 20 kg and BMI of 20. And she is afebrile at the time of examination with the heart rate of 86, BP of 130 over 76, and saturation of 97% on room air. And she had a respiratory rate of 16. On examination, there was no pallor, icterus, there is no clubbing, lymphadenopathy, or pedal edema, and there is no signs of Common examination. On inspection, abdomen is flat, umbilicus central inverted, the quadrants move equally with respiration, and there is primarily healed laparoscopic port scars was noted, and there is no visible lumps, sinuses, engorged vein, pulsation, and the bilateral linear angle, there is no fullness, hernial orifice, there is no cough impulse, and there are two drains noted, one in the epigastric region, other in the right hypochondrium, draining turbid bile about 200 and 400 ml in the bag. On palpation, abdomen is soft, not tender. Abdomen is soft and there is mild tenderness in the right hypochondrium. Liver and spleen are not palpable, no other lung palpable, and hernial orifice examination is normal. On percussion, there was no free fluid in the abdomen. Liver dullness starts at the 15 intercostal space and liver span of 13 centimeter. The rest of the abdomen is tympanal. On auscultation, patient in normal bowel sound. On rectal examination, sphincter tone normal with there is a pale stool staining which is present. To summarize, after the examination, so she is a 65-year-old female, post laparoscopic procedure 3 months back. Initially uncontrolled, now controlled biliary fistula with controlled biliary external fistula. Examination, there are brain rates one in the east, and one in the right.
So external biliary fistula controlled. Is it controlled or uncontrolled? Dr.
Well, there was a turbid bile which was there in the bag, sir. So, and fever, though.
In between, you are not audible. Something problem in your. Yes.
Am I audible, sir, now?
Yes. You are audible now.
Yes, sir. So, it is
If your internet is weak, you can go to only audio mode because you can switch off the video. It's not coming in between. Yes, go.
sir. If the drain is her drainage bag is still having turbid bile, sir. So, and she is having a
Tell me
uh,
the question. You start explaining every day in Monday clinics we tell. Please answer the question first and then start explaining. So first tell me whether it is a controlled fistula or not.
yes, sir. It to be controlled fistulas.
Okay. So you did not mention anything. Is it this patient belongs to your center?
Yes, sir. She was referred to our center, sir, after percutaneous drain placement.
Well, I know that bile duct injury has occurred in some other centers. It has come to your center now. And
Yes,
now
sir.
it's admitted in Rishikesh AIMS.
Yes, sir.
So nutritional assessment, you still did not do it to present in this case.
Uh,
A patient is for 300, not a single drop of bile has gone into the tummy, and still you have not tried to go into the details of the nutritional assessment, which is not acceptable at all. Which is, I am repeating, Dr. Anand has come to your center now. I think it's our big responsibility to look into all these factors. What changes will occur in the skin? You tell me if there is fat is not entering there.
there
Medium
will be
chain triglycerides are not going. Short chain triglycerides are not going. So what changes you expect in the skin of the patient?
there will be dryness of the skin, sir,
That's
and
all.
thinning.
So 300, and initially it was, she was getting 7 to 800. Now you are saying it is getting 200 and 200. How much is getting nowadays total output?
Sir, it is still draining around 800 ml, sir, but the bag at the time of examination I had that much, sir.
Okay. So it is, daily output is still 800 ml per day.
Yes, sir.
Okay. So how do you minus 300? When did he come? Did she come to your center? First time after biliary frontal fistula or recently she has come?
Sir, after the after the first drain placed, she came to our center, sir. Then we got another drain placed.
So after you are, then you must have sent home to the patient. Or you have admitted for 3 months continuously.
No, sir. We didn't admit her for 3 months, sir. Then she went home again. She came back with 1 or 2 of fever. For further evaluation, we admitted, sir.
When you are discharging a patient draining 6 to 700 ml per day, how do you teach her? As a registrar,
Yes, sir.
what
Sir,
are,
we had advised her to. We had sent the bile for culture, sir. Bile culture was sterile, so we advised her for bile refeed along with to take plenty of ORS
Mhm.
uh,
Okay.
and to review in OPD frequent.
I repeat ORS, that's all.
High protein diet is advised, sir. High protein calorie rich diet along with bile refeeding and ORS and to frequent follow up in OPD.
Any measurement of the output? Did you ask her that when in pharmacy?
Yes, sir. To daily measurement of train output, sir.
You tell that you talk to us immediately once this thing happens, something happens, you tell us. This is all senior resident should be doing. When you are discharging a patient with a bile dyspnea, patient is in agony. What are the things you explain to the relatives
Uh,
and patients?
yes, sir. We'll explain that uh, uh, this this condition is curable, though but it takes longer duration and requires so requirement of
You can 100% cure a bile injury. Have you read the articles about the long-term morbidity and mortality of the patient with bile duct injury, even in a managed invest centers? You are not yet aware what type of injury has occurred.
majority of the patients. Yes, sir.
So nothing
And
is, the one patient is one patient. So now you will tell that did you tell that this thing has happened? She will say, why don't you close my this fistula output? Take the drain out and relieve me of this thing. Then what will you tell?
that patient, I will explain her that uh, there is we have to wait till the structure to mature till the
You
that
just
is for
that you know what is structure. So I just want to see everything in our center also happens. Boys are so much robotic now. So word by word you have to explain. Did you tell that no, we cannot manage at this particular time because why? Why if she says that no operate me, then what will you say?
main two things are: one, to optimize the patient nutritionally, and also second thing is to the healing of the structure take place.
It has not
Uh,
healed. It is still taking 800 ml. Then why have we admitted her? Still it has not healed. No? Still you have admitted for the surgery or you have admitted just for some problem.
admitted for fever, sir, and also to mild fever was there to evaluate that, and if there is a controlled fistula, then to optimize and to plan for surgery.
You are saying that I will wait for structure to develop. Structure has developed, do you think?
No, sir. Picture is not developed, sir, but there is already patient at 3 months since injury. If it's a controlled fistula.
I asked you, you said I will tell that structure should develop. Structure has not developed. So your answer is inappropriate. What are the better answer you can tell the patient that I will not do this because of this?
I'll explain the patient, sir, not do surgery before 3 months uh, with a high output fistula, with a high output of drain, because there is increased chance of reoperation rates and increased chance of again requirement of second surgery and
Okay.
further.
Listen, Mr. You people don't. Clearly tells that you don't explain the patient properly. You will tell that this surgery, if I operate at this time, the healing might not occur and my operation might fail. Is it a better answer or your answer is better? Dr. Binay, where are you now?
Sir,
If
yes, sir.
you tell that operation at this time is may not be successful and even long-term outcome is not good when I operate at this time.
Yes, sir. I will
What
explain.
is percent about 3 months? Why not wait more?
Sir, waiting for longer duration, the increased chances of developing into secondary
Long-
biliary cirrhosis.
How many months?
Like more than 6 months. 6 months, sir.
So 6 months and 3 months there is a gap of 3 months.
Cirrhotic changes will start after 3 months, sir, but there is increased chances after 6 months.
The article about this that in a external biliary controlled fistula where bile is draining and you start developing this secondary biliary cirrhosis in 3 months.
Okay.
Any article or you are just guessing?
So 6 months is the answer.
So let me tell you, this is all conjecture. There is a difference between the recurrent obstruction, internal fistulization, where there is a recurrent fever. There is a difference. When there is total bile is draining, the chances are more of nutritional derangement rather than thinking about the secondary biliary cirrhosis, because there is no etiology to produce the cirrhosis. There is no partial obstruction. Nothing is making your liver cirrhotic. Only thing is that one, there is a narrowing, partial narrowing, when fistula output goes down and there is a development of partial stricture, then there is a recurrent cholangitis, low grade, and sometimes internal fistula, that is also low grade cholangitis, which occurs recurrent and it is neglected, then secondary biliary cirrhosis develops. So not that if fistula is draining 700, 800 ml, it is difficult to control the nutrition rather than thinking about this. And at the same time, the operation done, suppose somebody operates like you, first time you control the fistula and you operate it, go and do hepatocogenostomy. Are there some people who suggest this? Are you aware of that?
Sir?
Are you aware of early repair of bile duct injury?
Yes, sir. Early repair.
There are many people do it. How will you counter? What is the evidence in the literature that early repair is not good?
Literature has shown, sir, with early repair there is increased chance of restricture rates and the requirement.
देखिए इंटुबेशन का भी तो दिक्कत है ना, फाइबर ऑप्टिक चाहिए कि क्या चाहिए.
Please mute other people. Hello, Dr. Vinay.
Yes, sir.
Are there some evidence you have read? Don't say literature. Tell me this, which literature? At this stage, you should be doing this publication. This publication, there are multiple publications up to 2021. Which publication suggests that early repair is sought with poor outcome?
Sir, I cannot.
So then you are my dear, you are presenting a bile duct injury. You did not even bother to go and read. There are about one Danish trial, one this is from France multicentric this thing. Danish also multicentric. Then 2021 again it has been published in this thing suggesting that early repair is not good. So that's why we suggest. It's not that literature has told. Literature has told is a very vague answer. Doesn't fit into the person who is going for the appear in a exam after the MCH. You must know this rather than telling that literature suggests. It's a very vague answer. So now tell me first, what will you do? So let's stop here by saying that external control biliary fistula needs lots of nutritional monitoring, very vigilant this thing follow up, and the patient should give you should have a phone number. They should have a phone number of some resident who can inform if there is a fever, if there is a slippage of the tube. Immediately the treating unit should be knowing it. It's a benign disease, needs lots of effort. So if you just put it vague, then it is going to have a multiple complication. So now go ahead and tell this thing. So how will you proceed now? It is now 3 months. Your 3 months sacrosanct period has come up. Now what are you going to do?
First, I will ensure that the patient is.
Again, you are away from your mic and not audible properly.
No, sir. Hello.
Your audio has a problem, Dr. Vinay. Hello.
Am I audible, sir?
So now it's better. Why can't you come closer if you are a recurrent problem you are having? Yes, go ahead. Now what will you do?
Yes, sir. Now I'll ensure that patient. I'll ensure the sepsis control, sir, by ensuring that patient is having normal proper counts with normal the CRP.
Again, you go away when you start. You go away from your mic. I think you should be closer to the mic.
sir, now. I'm audible, sir.
Yes, now you are. So when you say I'm audible, you are, I think, closer. The moment I said yes, then you go away. Yes.
Yes, sir. So now I'll ensure that patient is out of sepsis, sir. That is by checking the leukocyte count whether it is normal with the normal CRP and procal levels, and correct the coagulopathy of the patient by vitamin K injection IV, and to ensure our nutrition will get a LFT along with the glucose albumin level, and after we are sure that patient is having a controlled biliary fistula, no other collection, she is not in sepsis with a normal PTINR, and once she is nutritionally adding optimize at least a vitamin more than 3, now we can plan for further imaging and surgery.
What further imaging?
So no ultrasound is not showing any collection, sir. I would like to get a CECT of the one. First,
Stage after 3 months, how CECT is going to help you?
any presence of any vascular injury, but
So how does after 3 months it is going to help you? 3 months already passed, then you are going to identify the vascular injury. Then how it is going to help in your management?
but
Huh?
associated vascular injury can have a atrophy hypertrophy component.
So I think it's a very vague thing you are talking about. You people have not gone into details, just listen some lectures by some people and then start talking. It is now already 3 months. So which vascular injury you are suspecting, which is going to affect your outcome? Only few minutes are left, Dr. Binay. If you sleep in between the questions, then we cannot complete even basics. So at 3 months, which vascular injury is going to affect your further planning?
Vascular injury not.
Again, you are away from the mic.
Vascular injury will not. At the 3 months, vascular injury will not affect.
So why you want to do CT scan? You said that I want to do CT scans to see a vascular injury. I don't understand why you people answer, then you go away from your answer. You have said, no? You told that I want to do CT scan out now after 3 months to see the vascular injury. So can you correct by saying that I will want to do this one now? You are again not audible.
MRCP.
MRCP, no MRI.
MRI with MRCP, sir.
To give the complete answer. So why do you want to do CMRI? It is an unnecessary wastage of the money. What are the things you will see in the CMRI which you cannot see in MRCP in the management?
Is there any
So if MRI has been done, please show us, because again you are not audible. I'm tired of this repeatedly no audible, no audible.
MRCP image?
Your voice is not clear. I'm fed up with this thing. Okay, go slow, go slow. Yes, yes. Uh-huh. Go on reading.
There is showing that there is a left hepatic duct, like product, and is showing the right anterior sectoral duct, which is forming confluence with, which is joining the left hepatic duct, and right posterior sectoral duct also is joining the.
Can you go to CMRI picture rather than going to MRCP? Contrast enhanced MR. What are the things you would see in the contrast enhanced MRI?
If there is any undrained residual collection, and if there is any
Louder,
crowding of
little
the
bit louder, please. Undead collection and
bile duct, sir, which suggests there is any atrophy
what you will see in the MRI, MRCP? What are the things you would see in CMRI? Okay, go ahead and show the bile duct. If you must read what are the things changes will occur in the MRI if long-term injury has occurred and it has been not been taken care of.
there is the left ductal system is supposed to be dilated, sir. Right anterior posterior sectoral duct generating of the
I'm not able to understand anything what you are speaking.
dilated left ductal system, sir, which is forming and the right ductal system is also uniting and forming the conflicts. And we know that cannot able to make out the ductal continuity.
Mhm.
This one pocket of collection anterior to the
This is T2 image or T1 image?
this is a T2 image, sir.
So why don't you shoot T1 images? You wanted to see the vessels, now you don't want to see at all.
To see the weather's vasculature, sir.
Okay, show the reconstruction of this MRCP. Now it is already 9 o'clock. It's going to be there. Okay. So read it now.
So there is a left hepatic duct, right hepatic duct, sector, right anterior posterior sectoral duct are forming the confluence.
Dr. Binay, repeatedly you are not audible. Put a marker and tell this is what, this is what.
This is segment 2-3 duct, sir.
Yes.
And this segment 4 duct,
Hmm.
and which is forming a left hepatic duct, sir.
Uh-huh.
And this is the right anterior sectoral duct,
Uh-huh.
and this is the right posterior sectoral duct, sir.
Okay.
And they're forming a confluence, and however, below the confluence, the biliary continuity is not there. So this is a type 3 type 3 biliary stem.
Yeah, have you any better picture than this? Can you rotate it?
So there's static image.
So we don't have another image.
This image is this. So
Mm-hmm. Okay.
left duct, right anterior posterior all uniting below the confluence. There is a discontinuity, and the distal bile duct can be visualized.
So now what will you do? 2 minutes are left. Just in 2 minutes, finish your this thing.
After nutritional optimization,
You are not audible. You are not audible, my dear. Nothing is coming this.
after nutritional optimization and sepsis control, then we'll plan for surgery, sir.
What surgery? What surgery? How will you prepare the patient? What is your expected albumin level?
It should be at least more than 3, sir.
More than 3. And other parameters?
And INR coagulopathy should be corrected. INR should be within normal range.
Okay.
And sepsis count should be normal.
Uh-huh.
Normal CRP. And the decelerating should be corrected, sir.
Did you do a CT scan at your center at 3 months? At Rishikesh AIIMS, have you done CT scan to see the vessel injury?
So this CT was done, patient had get fever episode. Ultrasound was not clear, sir. Look for any underlying collection.
Uh-huh.
Not detected on ultrasound. We got a CT.
So in a few lines, you just tell how you do a hepatico-jejunostomy.
Place a subcostal incision or a midline incision, and or bilateral.
Come closer to the mic.
Yes, sir. Place a midline or a right or a rooftop incision, sir. Then followed by we'll do adhesive dices starting from right side towards left side by carefully adhesivizing and we'll keep the percutaneous drains intact. And before that, preoperatively we'll place the percutaneous PTBD catheters under IR guidance for intraductal identification in case of.
In this patient, we will do percutaneous. In this MRCP, do you need a percutaneous every time or no?
It's type 3 and type 4 orange fluid will routinely.
In type 3, you are doing routinely percutaneous.
Sir, if it is like type 3, it is confluence is just forming like that type of.
You are adding so many ifs and buts that I am confused about my approach in bilateral. You are making a simple question more complicated. Simple is in type 3, do you do a routine PTBD? And if you do, which duct you target? Okay, I think time is over, and I had a lot of issue with your audio, and that's why probably we could not do justice to the proper management. Just to summarize, we never do CT scan after 3 months. If you at all you want to do it, you do it early. Just to see, ultrasound is not a very good investigation. We always keep a very low threshold for a good CT scan to control fistula, so that each and every collection can be seen. If patient then percutaneous drainage tubes, suppose it is placed even in the operative period, and patient is sign of sepsis, then we do a CT scan and do this thing. If you want to document for the research purpose bilateral vascular injury, then early doing is of help, otherwise no. If you are fond of doing early repair, then also it is required, otherwise no need. After 3 months, there is no role of CT angio unnecessary, because if you should read the blood supply of the bile duct, it comes transversely and there is a good collateral between left and right. So usually doesn't require after 3 months just for documentation. As for the research purpose, you can do it. Then CMRI and MRCP is the choice. A proper preparation is the most important. And type 4 and type 5, we do a PTB tube placement before operation. Or any setting of cholangitis is there, then obviously it will require a drainage if it doesn't settle with the antibiotic. What is my district? Anand said that I should finish. Any question anybody wants to ask me, please go ahead, or we will stop. Anybody want to ask any question, Dr. Binay? So if you know, thank you.